Welcome to another Prodigy EMS webinar. We are pleased to have you join us for Improving EMS Care of Sepsis, a Tale of Two Agencies. I am Hillary Gates, Director of Educational Strategy for Prodigy EMS. You'll be receiving 1 CE credit for today's webinar, and we encourage you to share the recording of this webinar from prodigyems.com. It is past time to address the controversies surrounding pre-hospital fluid resuscitation in patients with sepsis. Most importantly, EMS has not been included in much of the recent sepsis research and in the construction of sepsis guidelines. In this webinar, 2 EMS agencies present remarkable data that show the benefits of early fluid resuscitation in this population. The end goal, of course, is to empower EMS clinicians to provide the most effective care for patients who are septic. And we thank LifeFlow for supporting this education. I'll now turn it over to Dr. Peel to kick us off.
Thank you, Hillary. Super exciting to be here. We want to talk today about sepsis, and in particular, how we can better manage sepsis in the pre-hospital environment. And what I'll do is give a background on some of the data and just definitions of sepsis, some of the confusion and controversies, and then we'll hear from 2 agencies who are making a difference by improving sepsis care in their environments. So first of all, let's talk about what sepsis is and why it matters. It's a very common disease in the US, over 1.5 million cases with fairly high mortality. In septic shock, the most severe kind, there's up to 80% mortality in some of these patients if they present with septic shock. It's the #1 cause of death in our hospitals in the US, and also the most expensive thing we treat. So impacting this disease as early as possible not only will save lives, improve outcomes, but can save a lot of money for the healthcare system. It's also the most common reason for hospital readmission for patients in the US. I'm going to go over some definitions of sepsis. I don't want anyone to think you need to retain these. They're confusing, and I basically want to illustrate the evolving nature of the definitions and the confusion around it. So the old definition, what was called sepsis 2, defines sepsis as an infection plus a systemic inflammatory response syndrome, which includes 2 or more of fever, tachycardia, high respiratory rate, or elevated white count. And then severe sepsis was that plus some organ dysfunction, hypotension, altered mental status, and septic shock, hypotension that didn't respond to a dose of fluid and required vasopressors. That was the old definition. They were somewhat easier to understand than the new, which are now called sepsis 3. This is published in the link you see below in JAMA. It's now defined as a life-threatening organ dysfunction caused by a dysregulated host response to infection, which is not clean or easy to understand, unfortunately. And organ dysfunction is defined by something called the QSOFA criteria, which include tachypnea, altered mental status, and hypotension. So 2 of those plus a suspicion of infection equals sepsis. Septic shock now is called sepsis with profound circulatory, cellular, or metabolic abnormalities, not an actionable statement for any of us clinicians in the ambulance or in the ER. And those abnormalities include needing vasopressors to keep your blood pressure up, a lactate that's high, all after adequate fluid resuscitation, not responsive to that. And these things, septic shock, implies a mortality of at least 40%. And as I mentioned to you, it can be up as high as 80%. So it's very confusing for us to know what to call sepsis, what to call severe sepsis, what to call septic shock. And you'll see from 2 of the agencies that we're working with here today that even their definitions vary slightly. The Surviving Sepsis campaign is a big national movement to improve our care, particularly in hospitals. They recognize that sepsis is a medical emergency, and that after we recognize it, which is the first challenge, we need to treat it immediately with resuscitation, including fluids. This document includes 93 recommendations on how to manage sepsis, how to recognize and treat it. And Peter, I'll throw this question to you. Of those 93 in this big important document, how many of them do you think address EMS sepsis care?
Let me think long and hard about this one, Mark. Probably 0.
It's exactly 0. Not even probably, it's exactly 0. So the vision for the national organizations dealing with sepsis does not include the idea that we should be managing this well in the pre-hospital environment. So that's what we're here to talk about today. Quickly, you'll hear the term SEP1 bundle. This is what Medicare is asking hospitals to adhere to improve sepsis care. The Surviving Sepsis campaign is participating in this, and it essentially includes a bundle of care, or recommends a bundle of care which includes measuring lactate, drawing blood cultures, administering antibiotics early, beginning at least, if not finishing, rapid administration of 30 per kilo of fluids for resuscitation, and then adding a vasopressor like norepinephrine if that patient is unresponsive. Again,
Mark,
none of this is envisioned to start in the ambulance, although much of it can. Pete.
yeah, I mean, those last two slides just show that those folks don't recognize that EMS is part of this bundle, if you will.
Yeah.
And they saying that these things should begin in the hospital. And I think that it's very important for us to shine the light on the pre-hospital setting where really sepsis care should begin.
Right. Absolutely. And we can make a big difference in outcomes if we actually take seriously that things should begin immediately and recognition should begin early. And we do that in the field long before the patient arrives in the ED. So let's just remind ourselves what we're talking about in the first place that we're treating here, and that is shock. Not enough oxygen getting delivered to the tissues, not enough red blood cells containing oxygen getting to the tissues that need that oxygen and coming back to obtain more in a timely fashion. So when the supply of oxygen is less than the demands of the body, tissues start to die, tissues meaning brain, heart, lungs, and the patient ultimately can die of this. So we're treating effectively shock when we think about treating sepsis and septic shock. So what causes shock? Just as another quick bit of background, 3 big causes: hypovolemia, losing blood or fluid; distributive, where the vessels dilate, think of anaphylaxis and sepsis; and cardiogenic shock, where the heart doesn't work adequately to pump those blood cells around. Sepsis is a fascinating overlay of all 3 of these. So it's distributive, hypovolemic, and cardiogenic. In practice, most patients require some volume of fluid to begin that early resuscitation, and then other therapies like vasopressors targeted at the other 2 forms. Quick bit of also potentially boring physiology, but something we should remember: the Starling curve. You've heard it. All it means is that if we give a given volume of fluid to patients who are hypovolemic, their cardiac output, their stroke volume will increase, and they'll begin to deliver more blood around to the tissues that need them. So we're treating most of our patients with septic shock in the field and in the ER in the preload dependent zone, meaning they need some fluid to improve that cardiac output. Hypotension, let's think about that concept for a minute. Many patients, especially those with septic shock, will present with hypotension. And again, that definition varies. We know from a couple studies that a single episode of systolic under 100 in the ER for an older patient with sepsis predicts a 3 times increased mortality. So hypotension matters. Every minute that we allow the MAP to remain below 65 increases mortality and organ injury. Remember also that hypotension is a major risk factor for peri-intubation arrest. And of course, in TBI and stroke, hypotension can further worsen brain injury. So hypotension matters. It's a sign of shock, and it's something we should treat quickly. In agencies, in my neck of the woods here, these are a couple resuscitation protocols for how we deal with septic shock when we see it, and that is 500 ml boluses of fluid. Remember, also in kids, we're going to use about 20 per kilo of fluid for their initial 1 or 2 boluses. So why aren't we all just doing this? Well, there's a lot of controversy about the use of fluids in sepsis, and I share with you a blog post here from a site called PulmCrit, which just is pushing back against any mandates for any ER providers giving a given amount of fluid or interventions for sepsis, thinking we doctors know what we're doing. We know how to tailor our therapy to the patient. We don't want mandates from the government or from the Surviving Sepsis campaign to tell us what to do. This is a slide from a recent air medical conference where the same thought is given, that maybe fluid restriction as opposed to giving fluids is the better approach to sepsis. And I'll show you how some of the literature confuses people on whether we initially resuscitate with fluid or not. This tweet was based on a study called the Classic Trial and concluded that fluid restriction in septic shock is safe. And that makes me think, Peter, what does this make you think when you see fluid restriction is safe?
It makes me think that the Feast trial screwed everybody up back in 2015, where they actually provided data from non-septic patients where they withheld fluid, and then the entire world felt that we should be restricting fluid in our sickest patients.
Correct. Based on a study in sub-Saharan Africa of fluids given to children who did not have sepsis. And that created a number of studies, follow-on studies in adults, which suggested that if we give too much fluid, maybe we harm patients, which we can do in the ICU and in their hospital stay. But none of these studies teach us about the early resuscitation of patients when they first present with septic shock. And so I'm going to review the study that was mentioned in that tweet, in which they looked at adult patients in the ICU, Peter, not in initial resuscitation, who had elevated lactate and had already gotten 1 liter of fluid. And then they randomized them to some fluid or restricted fluid after that. And they found that most patients had already gotten 3 liters of fluid before their arrival in the ICU. We don't know how many of those were hypotensive and might have needed resuscitation earlier. We also don't know, fascinatingly, how many patients got fluids, were effectively resuscitated, and could therefore not even be enrolled in the study. And they basically showed that whether you gave 800 mils in the next day or 1,600 mils, there was no difference in outcome. So from this, people conclude fluid restriction is safe. Maybe so, but this is an ICU question, not an EMS and ER question.
And Mark, let's double click on this. There are patients who never made it into the study because they received appropriate fluids early, either in pre-hospital or in the emergency department, and therefore never made it into the classic trial.
Correct.
And so they're really eliminating a whole subset of patients who received better care to put them into a study of fluid restriction after they already got 3 liters of fluid before randomization.
Exactly.
It makes no sense.
And as we're going to hear, Peter, from your agency and from Matt Perry's in Georgia, there appear to be a good number of patients who, if resuscitated properly early, would never make it into this trial and are just better off because of it. I want to arm everyone with the actual data that shows that the SEP1 bundle, and I'm not necessarily advocating that everyone needs every component of it, but patients for whom providers comply with this bundle and get the lactate, the fluids, the antibiotics going early, live longer and are more likely to get out of the hospital with fewer complications and stay in the hospital less time. So among 100,000 patients studied, the SEP1 bundle I talked to you about, which suggests that we give early resuscitation and early antibiotics, did reduce mortality and length of stay in that population. So there are good data, including one that includes EMS studies. Fascinatingly, there are EMS studies out there which look at the effect of timing of fluid on mortality. This study from Michael Ward reviewed 5 retrospective studies, 2 in the EMS environment, 3 in the ED, and showed, if you look at the bottom bullet, that patients with hypotension who got their fluids earlier were half as likely to die, suggesting that early moments of care, early recognition, and early resuscitation matters. All you need to pay attention to on this slide is the blue diamonds. If the blue diamond is to the left, you have less mortality for the given intervention, in which in this case is the full bundle of care, or particularly of early fluid resuscitation. The ACEP, American College of Emergency Physicians, validates this also, suggesting that we use discrete boluses of fluid titrated to effect, meaning hypotension, we give 500 up to 2 liters, and try to reverse the hypotension and septic shock that we see in our early management of patients, and that this is also evidence-based, based on the studies that I showed you. Can we give too much fluid? Yes, as I mentioned, it's my fault, Peter, in the ICU when patients get too much fluid and look like the Michelin Man. This is a graph of daily fluid intake in one of my own patients in the ICU where we gave probably too much over 4 days' time. It's rarely the responsibility of you in the ER or your team in the field giving the right amount of fluid early to reverse septic shock. So quick bit of EMS data. Older study, a little over 10 years ago from Seymour and others, looking at how much more common sepsis even then was becoming than many of our other big diagnoses in the pre-hospital environment. Many, if not now, most patients with severe sepsis and septic shock arrive by an EMS provider. They spend a good bit of time in the field. 1/3 in this study got any IV or fluid of patients with septic shock, 1/3. And those who did got an average volume of 300. So not a lot of fluid was given for resuscitation in any of these patients. But those who did get fluid had decreased mortality and less organ dysfunction, and the effect was most pronounced in those who had septic shock and or hypotension. And you can see here, mortality on the left, 30% if they got nothing, 15% if they got both an IV and fluid. And fascinatingly, patients who got an IV alone were less likely to die. Why is that? Probably because they had the portal of entry for the fluids to be given on arrival to the ED rather than extra time being spent gaining access. Any thoughts on this one, Peter?
Yeah, no, I just think that when you look at the mortality, and you've mentioned it, that can go from 40 to 80%. When we look at our data in EMS, we see that we have so many sepsis patients and septic shock patients compared to anything else that we do that's kind of the highly critical thing. So when you're talking about a reduction in mortality that's half, you're talking a lot of people. And you'll see later on when we start talking about both my agency and the other agency in Georgia, that you're going to start to see that the numbers of patients, even at smaller volume agencies, are pretty large. And so this data is very, very important for people to understand.
Absolutely. Another big study more recently particularly looked at patients with hypotension. They found that only half of patients now, in a study that was published several years ago, receive pre-hospital fluid. And again, a 400 milliliter average volume. So that's about what people could do in that 45-minute pre-hospital time. And earlier fluid was associated with improved mortality, once again, for those with hypotension. And they defined that as under 100, Peter. So there may be thresholds that we should think about adjusting, especially in our elderly patients who at baseline may have hypertension. And so a pressure of 100 or 110 is actually quite low for them. We here in Wake County and at my hospital, Wake Med, evaluated our patients coming in with sepsis by Wake EMS. And of those patients who were brought in with sepsis, half had septic shock, so a sick population. Once they got to the hospital, only a quarter of patients in a big busy hospital received 30 per kilo in 3 hours. A very low bar, 3 hours to get that 30 per kilo in. Only a quarter received that. And if they did, even in that longer time window, they had almost half the chance of death as those who got their fluids later. So even in the ED, earlier fluids made sense. Could we push that into the field and make a bigger difference in these patients' lives? And you'll see that the answer is yes. All right, lastly, Peter, I wanted to share this study I had the opportunity to be a part of down in the Jacksonville area of Florida with Orange Park and Clay County EMS agencies, where they decided to implement a tool for improving their fluid resuscitation, which was LifeFlow. And they looked at how they were doing with sepsis management before they implemented that device, and then evaluated patient outcomes after the implementation. And they found that in the pre-group, before just by standard care, they were giving about 250 mils of fluid to these patients with septic shock. And that after they implemented the device, that went up to around 1 liter to 1.5 liters in their pre-hospital time. And so then we looked at the impact of that difference on mortality and compliance with that SEP1 bundle we discussed and other patient outcomes. So I'll show you some results here. In the standard care group, the group before the implementation of a new method to give fluids, they found that about 70% of their patients were counted as critically ill. They got the 250 in, and their fluid volume in 3 hours was about 20 per kilo, so less than the 30 per kilo recommended by the SEP1 guidelines. After they implemented the rapid infuser, interestingly, the group in the post phase happened to occur during a Delta spike in COVID, so they were sicker. They got more fluid pre-hospital when they implemented a tool to do that. Most of them met their 30 per kilo goal in 3 hours. And then when we looked at the total SEP1 bundle, all those things we talked about, antibiotics, lactates, resuscitation, That improved to 84%. So that helps hospital reimbursement and also helps patient outcome. All the patients in the group who got enough fluid had their hypotension corrected. Fewer of them went to the ICU. Those who did go to the ICU stayed fewer days. And interestingly, those who got more fluid actually required less intubation in the ER and had less incidence of hypoxia, counter to what we often think. We give more fluid, we cause more hypoxia. It's the exact opposite with septic shock in this group. And then lastly, we showed that the mortality, though low in the first group, was exactly 0 in the post-implementation group, though that was a sicker bunch. Quick disclaimer, these results are a small patient population. It was not a statistically significant change in mortality, but nevertheless, the trend in all these results were positive and point toward, I think, what we're discussing in the upcoming stories we'll hear from the two agencies. Peter?
Mark, this is incredible data. I think that if the folks who created this concept of forcing hospitals to do the right thing for sepsis, they just recognize that EMS is where this starts. You know how many patients could be saved? And the paradoxical item you just spoke about, which is more fluid led to less mechanical ventilation, led to less hypoxia, and of course, reduced the mortality to 0. This is incredible. And I think you're allowing us to finally see that fluid for sepsis is just like whole blood for hemorrhage. This is
Absolutely.
incredible data.
So let's move to the next phase and hear some stories from the field that will be very inspiring.
Thanks, Dr. Peel, so much for the opportunity to come and speak to everybody today. This has been a passionate subject for us here at WellStar EMS, and we've used the shock management, especially with sepsis patients, as a bit of a foundation for growth for us. We look at our ambulances and we look at EMS in general, and I've heard it recently put that the biggest myth in EMS is the E, the emergency side of it, and I thought that was telling. And then I've really started to build on that. And I think the E needs to stand for effective. Like, you need to build effective ambulance services. And it's not just a ride to the hospital. There's a lot of medicine that can go on and really show that your profession is valuable long term and for the short time you have these patients. And so we started to focus on shock and sepsis. We've built our ambulances around the two big wheelhouses for EMS, the first one being acute respiratory emergencies, and the second being shock. You should be able to handle those effectively and make a big difference for the patient. And so we implemented and really started, once we found a rapid infuser for us, that we knew that volume was important. Let's get those pressures up and let's start our brain and heart and lungs perfusing. So organ damage was important. And we found one, and then we implemented, let's focus on what kills 50% of the patients in a hospital, sepsis. And that's where we started focusing. And after we've done so, we really started to build an opportunity for the crews to feel like they did something at the end of the day, right? You're not just given a ride. So let's give you a sense of satisfaction that, yeah, you may have gotten your teeth kicked in today, but guess what? You made a difference, and you made it for not just you, but your patient, your partner, your service, and your reputation. So that's what we really started to do. And when we looked at our sepsis cases and our sepsis patients, we saw early on we were making a big difference, and it was not being recognized anywhere else. You got into the hospital and they would roll their eyes at you, but they would also say things like, hey, I thought this patient was sick. Like, you've made that big a difference for them. And so we looked at these cases, and now we've really started to take a look at it. And so I've just pulled the last 50 documented cases to show you how big a difference you can make. So the last 50 cases where we looked at patients of septic shock management and where they were in either a severe sepsis category or septic shock, or they were trending for, we call those the getting sick patients, right? You know your patient that's really sick. You know your patient that can go to the waiting room. But what are the ones in the middle where we tend to miss, where we can have a massive impact on them? So the getting sick. So if you look at our cases in the last 50, 35 of the last 50 were in a septic shock or had a septic alert kind of patient. 13 of those were just nausea, vomiting, diarrhea, dehydration. And if you look at shock overall, think about those patients in the compensated shock setup, right? They're becoming maybe a little hypertensive. They're becoming a little tachycardic, right? Their respiratory rate has increased. If you're not using end-tidal CO2 every day, And, I used to kid around and say every PCR is falsified. And people would look at me and they kind of shuffle in their seat. And I would say, what's your go-to respiratory rate? And then they would all sink in their seat. And I was like, we're making that up, aren't we? Jesus is watching. So let's be careful. And now that they have end-tidal with an accurate respiratory rate, those vital signs matter, right? You're now seeing trending towards sick patients. And then you look at the DKA patients where they're all of a sudden we need a profound volume quickly, like they're really starting to get sick, and we need to start addressing their perfusion. We did not include patients that were in cardiac arrest or we were pulling out the Lucas devices and getting ready to handle that peri-arrest patient. Over those 50 patients that we included, we had administered via a rapid infuser over 80,000 mLs of normal saline or lactated ringers pre-hospital. We were doing big fluid resuscitation over those folks, but we only averaged about 1,600 mLs per patient. So when you're looking at what was given on the front end, you're not fluid overloading. So those patients that may have dialysis issues, or renal failure, that may have congestive heart failure, or you're dealing with some kind of other metabolic problem, you're not flooding them out. What you're doing is you're correcting that perfusion, and we're getting those pressures up, and we're getting heart rates down, and we're starting to make them a little more comfortable. This has been important for us, and we've seen a lot of benefit to these patients. When we look at them, the average age of our patient was about 71 to 72 years old, but our youngest was 31. The youngest patient also got the most fluid in the field and had a series of problems with them, but they got almost 3,000 mLs pre-hospitally and still needed a pressor. So we were looking at those patients. Our oldest was 99. In 40 of the 50 cases that we dealt with, the hypotension was resolved. We fixed their hypotension and maintained a normotensive state with good maps and changes in mental status. 22, almost half, had cases where their GCS significantly improved. Now understand, a bunch of them also had GCSs of 15. So they were already awake, alert, oriented to their normal baseline, which was good. Of those 6 cases had a GCS where improved. There was less than 10 and got them all the way back to a normal mental state. The big factor here is that 48 of the 50 cases left the hospital. We had one that was a DNR, DNI that didn't leave, and I've got one I'm still trying to dig into a different hospital. But right now, the preliminary data is showing that these patients aren't staying. Now, we haven't seen length of stay issues. We're still looking at those. But overall, we're seeing some positive trends where we focus on shock, fix the shock, get the perfusion up, get their brains perfusing well, get their heart and lungs perfused, and give the hospital staff something to work with. When you start to see that level of acuity drop, you see them to be able to get their feet under them far faster, and they're not behind a curve.
If I'm understanding correctly, you had 35 that you thought were septic shock. Presumably most of those were hypotensive because you had 40 hypotensive cases.
Yes,
and
sir.
remember that those patients have a risk of mortality around 40%, hypotension and septic shock.
Yes.
And no one that we know of died.
Correct.
So this doesn't prove anything, but what you're suggesting is that the resuscitation you provided gave them a better chance of survival.
Oh, yeah, without question.
I also have a follow-up. I mean, this is incredible data, and I think this is why it's so important for EMS and agencies like yours, like ours, to begin to contribute more strongly to the literature base. My question for you is, at what point did you start adding in the pressor? Is there a threshold by which you say you can only start the pressor once X amount of volume has been administered?
We did. We said we need to give the body something to press. So we will give them a 500 or 1,000 ml bolus just to see what happens. And in a majority of the cases, we saw upward trends in pressures. What we really had to work on is getting the crews to understand that giving them 1,000 via a LifeFlow and you got to do a little bit more than that. So just because they're trending upward doesn't mean they're perfusing. And so pushing that against that fear of using Levofed or a push dose epi, we had to work through that. The biggest way we work through it is I got pumps on ambulances. They're afraid of the math. just to be completely transparent. And so when we took that fear away from them and gave them a little easier way to calculate and manage and control it for them, they really started to use it and thought people were far more accepting of it. And the data continues to kind of come in where I'm seeing more and more use of it. They're getting more and more comfortable, and our outcomes are getting better and better and better. And that was important.
I think that you're hitting on a couple of very important items, Matt, and a couple of things that have been, I think, practiced incorrectly for many years. Is that normally when someone said, I'm going to give a fluid bolus and then I'm going to start pressors, that fluid bolus in the hospital or in the back of an ambulance, well, especially in the hospital, we would put, 999, right? The classic, having that leader going over an hour. But we don't have an hour with these patients.
Yeah.
So I love what you're doing in that you're giving fluids quickly, right? It's not taking you, it's taking you minutes, and then you're transitioning to pressors rapidly thereafter. And so I think that we need to start thinking of pressors much earlier in the sequence, and by giving fluids rapidly, that enables us to do everything in the back of the ambulance rather than say, I'll just give the fluids now because by the time I get there, on average, I'm going to hit 300, which is not a lot. In this case, you're giving much more than that, and you're already starting pressors, and you're delivering patients to the hospital who look at your data. I mean, these people are all alive, except for those two who one may have had it's an unknown outcome and one's a DNR. But like Mark mentioned, when you have a 40% and sometimes even higher mortality with septic shock, and you're showing us cases here that have the exact opposite, we have to start paying attention to this and start to do more EMS level data to prove that EMS is where these patients live. And Mark, I'm even thinking, as I'm listening to this presentation, that fluids for sepsis is like blood in the field for trauma.
100%. 100%.
Exactly what it is.
I'd like to add two quick points here. The first is our scene times haven't moved. So because we're doing this, our scene times are still averaging what they normally are. So we don't have these prolonged on scene times that's causing us to have service delivery interruptions. So our scene times are staying about the same because they are recognizing it early and they are aggressively managing these patients. The second thing I'd like to add too is that in the cases I'm about to show you, when we focused on weight and predicted body weights and ideal body weights, when it comes to that fluid bolus, and the crews are now being far more cognizant of how far along they are in that chain. So when you said 999, we know that they need X number of mLs. And so we look at that in hours saved in the ER. So now they're 2 hours ahead or 3 hours ahead where they would be with that SEP1 bundle that you all talked about where the clock starts the minute they rolled in. Well, we just bought you 2 hours or we just bought you 3 hours. In the healthcare world, especially in hospitals, that's money. That's real money when it comes to that. So I wanted to add that. And you're looking at our case studies here. We had, I just threw two. The first one's an 80-year-old female found at home. Family said that she's starting to have some mental decline. And over the last 20 days, but really in the last 2, she started to go downhill. She was found by EMS. The fire department gave us initial blood pressure of 140/80, but when we did a physical assessment, we realized she didn't have any radial pulses. And so when we rechecked her, it was 60/40. Respiratory rate was increased. Her end tidal was 18. Her heart rate was 142, but her GCS was 10. She was very confused laying in bed. After an immediate fluid bolus, we saw a 1,500 mLs. We saw a change in her almost instantly. She maintained that pressure status and rolled into the hospital laughing and joking with EMS with a GCS of 15. And you can see the follow-up heart rate. And she maintained, like she didn't need pressors after that. She kept a good blood pressure throughout the time. But that 1,500 that we gave her was her 30 ml per kilo bolus. And she got that at home.
This is incredible. So a couple observations. Her shock index, 142/60, is 2.3.
Yeah.
Is that right, Peter?
Yep.
And that's a very predictive of death. And guess what also is? Her end-tidal of 18 probably predicts a lactate of over 4.
Yeah.
So hypotension plus high lactate is high risk. I want to say 50 to 80% risk of mortality in this patient. And yet you brought her talking to the emergency department.
Yes.
With probably, I don't know her weight, but let's say she's 60 kilos, 50 kilos. She's almost done with her 30 per kilo. The whole SEP1 bundle has begun to become accomplished before the hospital arrival.
Yes.
And guys, two items that are not even discussed in the sepsis campaign are shock index and then title, right? And clearly you can see here that without those values, I mean, it was obvious here when you had a 60/48, but adding in those values, it's the stamp of, yes, this is sepsis. We need to stay here and get this fluid on. You said it, Matt. It's not costing you any additional time. And then you bring in a patient who's laughing and joking with the staff. And by the way, if that patient was going to go to an academic center where one of these studies was taking place, she would not even be considered for that study.
Correct.
Because, by the way,
Yes.
she would not be in septic shock anymore, and she would probably go to the urgent side of the ER, not the emergency side.
Our second one is a 75-year-old female at home who's at home with home health, complaining of generalized weakness and hypotension. And they discovered with her, she had a bed sore and she's had an indwelling catheter with dark urine. You can see her vitals in the beginning. Again, there's that end tidal. And notice her temperature. One of the things that, we put really nice thermometers on here as we consider temperature is a part of a vital sign. But our crews also understand when hypothermia becomes a problem, right? That hypothermic infected patient, how far behind the curve you really are. She was given a total of 2,000 to 1,500 given rapidly. You can see her vital signs at the time of handoff. You see an improvement in her end tidal as well as her heart rate. And then her quote, and this was quoted in the report, she's feeling better after if you did whatever you did, right? So, she's, I don't know what y'all doing, but it's working. And she rolled into the hospital.
One quick comment here. She could have been on a beta blocker. Note the heart rate isn't that high. She still has a shock index of around 2, close to 2. So it's high, but here's a place where a heart rate can fool you if they're on a pre-existing beta blocker, just as a warning. But really, really an amazing story.
Thank you.
Matt, thanks so much for sharing those. In the interest of time, let's head over to Captain Lamb, and then we will chat about all these at the end.
Hello, everybody. Matthew, that was really good stuff. Those numbers are really impressive, and honestly, I'm kind of jealous of some of them. So some great data. Here at Gardens, we've learned a little bit about our sepsis patients and our treatment of those sepsis patients recently. Just so you kind of have an idea where this came from, around June of last year after the Eagles Conference in South Florida, we investigated starting a whole blood program. And part of that whole blood program was going to be to introduce a LifeFlow as a way to infuse the blood. While that process was underway and we were getting contracts in place and we were buying equipment, I kind of took a look at our sepsis numbers and was a little bit shocked by what we found. And we decided to, instead of waiting for a whole blood program to be up and running before we put the LifeFlows on the trucks, we decided to put them on early for a couple of reasons. One, to enhance the fluid administration to our sepsis patients. But the byproduct of that would be that the crews would already be super familiar with the piece of equipment for when blood came to the field. So we kind of landed on this a little bit differently, but as I'll show you in some of the upcoming slides, the benefits of introducing this into our system have made quite a difference. So before we get started, I just wanted to really touch on our protocol a little bit so we can kind of, when I'm going through the case study, you kind of understand what a sepsis patient looks like in Palm Beach Gardens. So this is our protocol. So anytime we go on a call where an adult non-pregnant patient has a confirmed infection or a suspected infection, we automatically screen them for sepsis. So as far as that criteria, it's got to be an adult who's not pregnant. They've got to have suspected or documented infection, and then we screen them to see if they have at least 2 of the 3 SIRS criteria, right? So that's a pulse rate greater than 90, respiratory rate greater than 20, or a temperature greater than 100.4. Should they meet 2 of those 3 criteria, then we fall down to our severe sepsis criteria to see if they meet our definition of a sepsis alert. So, and it pretty much comes down to hypotension, 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 altered mental status, or end-tidal CO2, right? So if they hit 2 of the 3 SIRS criteria, we come down and we evaluate them to see if they have a systolic blood pressure less than 90, if they have a diastolic blood pressure less than 60, or a MAP less than 65, or if they're altered, or if we have an end-tidal less than 25, which from what we learned is pretty indicative on the backside of maybe a high lactate.
Just as I mentioned this earlier, but in the Surviving Sepsis campaign, severe sepsis and septic shock have been collapsed together, which I believe is confusing. I like how you've outlined it here, because sepsis is a progression of severity. And so this protocol is interesting because you keep the severe sepsis category, which is kind of the middle ground. They're beginning to get hypotensive. We don't know if they're volume responsive yet or not, but it directs us to the appropriate therapy. So I like these criteria.
And Mark, isn't it? I was just
Peter.
going to say real quick that Matt in his protocol, he called them the getting sick patient.
Exactly.
Right?
I love it.
So nice.
Severe sepsis or getting sick. That's the patients.
And what we find, if I'm being completely honest and transparent, what we find is the majority of our patients fall into that severe sepsis criteria, right? So they're sick, they're getting sicker, they're compensating, but they haven't really met the septic shock definition yet. And for us, septic shock is a patient who remains hypotensive after fluid resuscitation. So
Correct.
A lot of these patients that we're seeing are patients that we're finding early who are getting to that point. They're compensating, but they can't maintain that forever. And we're actually getting there, administering the fluid and stopping them from getting to the septic shock phase of their illness, right? So, you know, I looked through our data for the last 2 years, and we haven't even given the pressor because we're fluid resuscitating them before they get that severe.
Incredible.
So that's kind of the criteria we use as far as the treatment. Even if they don't meet a sepsis alert criteria, meaning they don't have either of the 3 hypotensive states, they're not altered, and they don't have an end-tidal. Even if they have that infection and they have 2 of the 3 SIRS criteria, we still go ahead and give them fluid, right? So they can benefit from it here in South Florida. It has its effect. Most people are walking around a little dehydrated anyway, just because of the weather. So a little fluid never hurts. If they do fall into the septic shock criteria and they are a sepsis alert, we notify our local facility. We try to keep our on-scene times under 10 minutes. This is kind of something I would like to see change. You know, we're all creatures of habit, and this kind of snuck in there because the rest of our alerts, our stroke alerts, our trauma alerts, our STEMI alerts, we want to be off scene quicker. But I think the value of getting the fluid on board as soon as possible is worthy of a little bit of an extended scene time. We monitor their end-tidal CO2, and then we go ahead and establish 2 large 4 IVs, and we start off fluid. So we're able to give up to 2 liters of fluid for a hypotensive sepsis alert patient, but we give it in 500 ml increments because we want to see, you know, kind of what the effect is from the fluid we're giving. And that kind of becomes important in the case that I'm going to present, where the gentleman remained hypotensive until the very last 500 fluid bowls, right? So we've got all the way up to 1500 mLs, and it incrementally increased, but hadn't made a big jump. It wasn't until that last 500 cc's that we really saw a difference and saw him start to turn around hemodynamically. If they remain hypotensive after the fluid, we can give push pressor epi. I kind of would like to see that be given a little concurrently. If, you know, we're maybe a liter in or 1,500 cc's in and we're not turning it around, maybe a little bit of a pressor up front to start shrinking the container while we fill it. And then, although we can't officially pull a sepsis alert on the pediatric patient, we do realize that pediatric patients get sick and we get septic too. So we want to make sure we're adequately resuscitating those patients also.
And Captain Lim, just to clarify, you're not going to start an infusion of vasopressors. You'll just rely until you get to the hospital on the push dose. Is that correct?
Correct. Yeah. Push pressor dose epi. We took dopamine off our truck's last protocol revision,
Great.
and we are solely push pressor epi for our vasopressors.
Great.
So this is some historical data, and this is kind of what hit me in the face like a wet fish when we started looking at the at our treatment for sepsis patients. So on the left side, I pulled all of our patients from January 2022 through October 2023. That was a total number of 228 patients. We have a continuing quality improvement plan, which looks at all our higher acuity patients. So our sepsis alerts, our stroke alerts, our STEMI alerts, our trauma alerts. And we review all the reports. We extrapolate some data from the reports and we put them in a spreadsheet so that we can see how we're doing and if we're hitting our benchmarks. So we have a benchmark for our sepsis patients of a minimum of 1,000 mLs of fluid on the way to the hospital. If you see this, we had 228 patients. We did not meet our benchmark 65% of the time, which to me was kind of sobering, right? Because, you know, here we are, we're starting fluids, we're putting them on the pressure infuser bag, and we're doing all this stuff when we get to the hospital, and the vast majority of the time we're missing that benchmark, right? Which
It's interesting you were getting up to 700 though, interestingly. I mean, you were trying.
Yeah.
Right.
Yeah. So and that was averaged out, right? So that's the total amount of mLs given divided by the number of patients. So we were trying, and we would get 722 mLs on average, but 65% of those patients weren't even getting the, you know, the 1,000 cc's that the goal that we'd set for ourselves. So November 2023, as we were getting the whole blood program up and running, we're like, you know what? We are missing our benchmarks horribly. Let's see if we can get our numbers up by changing the way that we deliver the fluid. So traditionally, we'd be having these patients IV fluids on the pressure infuser bag, which sounds like it would be great, but you know as well as I do, when you have something that you kind of set and forget, then things can change. So 1,000 bag in a pressure infuser going into an AC 18 gauge cannula that you think is infusing large amounts of fluid, only to look over halfway through the transport and see the arm bends and no fluid going in whatsoever. The thing we liked about the LifeFlow is you're a little bit more up close and personal, right? So you're literally infusing the fluid through the device. You're closer to the point of insertion. You can hold their arm straight. You're feeling the site to make sure it's not infiltrating. So you know you have a lot more control over the fluid, and things don't get overloaded. So just through November 2023, through year to date, we went back and looked. There have been 68 sepsis alerts. We've only missed that benchmark 38% of the time, and we've hit that benchmark 62% of the time. So we've actually completely flipped those numbers, right? We've gone from barely making our benchmark to hitting it almost 2/3 of the time. So, and our average fluid administration has gone up a little over 300 cc's by using the LifeFlow.
How many of those were hypotensive, do you guess, of the 68?
So in order to give the fluids, then you know, we're routinely giving fluids even if their end tidal is low or they're altered. Out of those 68, I would probably say 2/3 had either one of the three hypotensions. So either the systolic blood pressure, the diastolic blood pressure, or the pneumatic.
Good.
So here's our case study. This was an actual case that we had. We had an 84-year-old male nursing home patient with a chief complaint of weakness times 15 minutes and a productive cough times 1 week. He was notoriously a poor historian. The story was bouncing around all over the place, but we managed to narrow that down through a close family member who was there visiting him that day. He had a Foley catheter in place, dark yellow, foul-smelling urine, along with the productive cough. He was on the nasal cannula at 2 liters a minute. Vital signs, for the most part, the heart rate was 98. His systolic blood pressure was 80/40, respiratory rate of 20. He had a oral temperature of 101.5, and his end tidal wasn't horrible, but his shock index was climbing. So his initial shock index is 1.23. To Dr. Antevy's point from earlier, we started looking at shock indexes when we started to transition from a rapid sequence intubation to a delayed sequence intubation protocol. We had a couple of really sick people who we had been intubating that had gone into peri-intubation arrest. And, the initial thought was, wow, they were really sick. But when we went back and looked at the data, we found out that their shock indexes were kind of high. So the shock indexes have been on our radar for about a year or so now. And it's something that just recently, thanks to Dr. Antevy's suggestion, we've started incorporating into our sepsis care also. So, and normal sinus on the monitor.
So, Captain Lamb, in this patient's case, we have suspected infection from 2 sources, probably some ultramental status, and then you would classify him by your criteria as severe sepsis, correct, with the hypotension?
Correct. Yeah, with the hypotension, he meets our criteria to be a sepsis. As the case progresses, we did our usual physical exam, O2, end tidal CO2, 3 and 12 leads IV access, and then we went ahead and administered 1900 cc's of fluid via the LifeFlow. The takeaway point here for us is, as I mentioned earlier, the first 500, the second 500, and the third 500 would bring his blood pressure up, but it was literally extremely incremental, a couple of points here and there. It wasn't until we got into the fourth 500 bolus that he really started to rebound and his blood pressure went up. That 1900 mLs of saline was given during a 12-minute transport time also. So it was given fairly rapidly during a 12-minute transport time. So here's his initial vitals and his destination vitals. His heart rate went from 98 to 82. His blood pressure increased from 80/40 to 111/49. His respiratory rate, 21, and tidal remained the same, and his shock index had decreased to 0.83. To kind of piggyback off Dr. Antevy's point earlier is, we don't see a whole bunch of true septic shock, but what we do see is this subset of patients that kind of hang out in the middle in the severe sepsis category that we can kind of affect treatment on pre-hospitally, so that when they get to the hospital, they don't really look that sick and they don't really have, the profound hypotension that they had when we first found them. So, everybody can recognize the severe shock patient, but it's this subset of patients in the middle that we seem to get the majority of that we can do the most good with. So if that makes sense. So here at Gardens, we have a fairly robust continuous improvement plan. We look and scrutinize all of our high acuity patients. So anybody who meets an alert criteria, be it sepsis, stroke, STEMI, or trauma alert, we look at those calls, we review the documentation, the EPCRs, and we pull certain information out depending on what kind of patient it is. The reason I like to bring this up is we're fortunate enough to have a really good working relationship with our local facilities. And for those of you out there that are watching this that don't, I implore you to open up the dialogue and the conversation with your local facilities, because there is a plethora of information out there that the agency and the hospital can share with the common goal of working towards improving patient care and the patient care experience, right? So we meet with all of our local hospitals on a quarterly basis. We review all of our alert data with them. They share their experiences with us, and together we kind of tweak little things here and there. This is this patient that was in the case study. So chief complaint of weakness, the duration. Glucose is one of the benchmarks that we make sure we get on all sepsis patients, the initial heart rate, the initial systolic blood pressure, and then the spreadsheet automatically calculates the initial shock index. So we do an initial and then we do a destination. And as you can see with him, he had an improvement in his shock index. As we scroll along, everything in purple refers to the EMS agency. When we get to the green, this is where the hospital data comes in. So we send at the end of every month, we send the hospital all of our sepsis alert patients. They fill in their columns, and then we get the information back. So we have so another cool thing that we did when we instituted the LifeFlow is we changed our EPCR setting to whenever we gave fluid to include an end administration time. That now allows the hospital to use the pre-hospital fluid administration as part of their sepsis bundle. So to your point, Dr. Peel, they're meeting their bundle time a lot sooner because the good portion of their fluid is already administered prior to them getting there.
That's
So
important.
look at,
I wanted to point out also your antibiotic administration time is less than 30 minutes. And a theory I have is that if we've provided, we can talk about pre-hospital antibiotics, which I think are valuable as well, but if we've provided fluid alone, their time to administer the next therapy, which is the antibiotics, is probably lower just because you pre-resuscitated that patient. I believe. We haven't proven that yet, but I believe that you're going to see improvement in all elements of the bundle.
Absolutely. Absolutely. The total fluid that the ED gave, and then the time the blood cultures were drawn. So this patient got blood cultures within 14 minutes, and they were receiving their first dose of antibiotics in 30 minutes. We also get an ED diagnosis and the final diagnosis, so that we can make sure that our criteria is indeed, or what we're calling an alert actually is, and that's verified by the hospital ED diagnosis and final diagnosis. And then what happened to them? Were they discharged? This gentleman was discharged back to a skilled nursing facility. So a little bit different to show you the spreadsheet, but I think there's value in it. And like I said, I believe there's really value in striking up those relationships with the hospital and monitoring your data, because without data, we really don't know how well we're doing, right? And I kind of blew the cobwebs up of the spreadsheet a little bit, and some of the initial numbers that we were finding were pretty alarming. So, but we're managing to turn that around now. So
I really like it. Really clean way to collect your data. Congratulations.
thank you so much.